Good morning, everyone, and welcome to today's webinar on underwriting asthma. My name is Andrea Rasser, and I will be walking you through one of the more common impairments that we encounter in life underwriting. As you may know, asthma is widespread, but underwriting outcomes really can vary quite significantly depending on the severity and the level of control. So today we will explore how asthma is evaluated during the life insurance underwriting process and focus on some of the industry best practices. By the end of the session, hopefully you'll have a stronger grasp on how asthma severity is classified, what factors underwriters weigh the most heavily, and how you as an advisor can position your client for the best possible results. So with that, we will jump right in. All right, so when we look at asthma, we'll start with the big picture here. Over 25 million Americans live with asthma every day. That is roughly 1 in 13 people. So chances are you probably have a friend or family member who's struggled with this at one time or another, whether you're aware of it or not. It is a chronic condition. It is, though, oftentimes very, very manageable with modern treatment. So while it does not go away, we can typically keep it under control. And when it comes to underwriting, these decisions are going to hinge very much so on the severity of the asthma, the level of control, and compliance with any treatment that their doctor has recommended. So again, just key takeaway here is it's very common, but not all cases are created equally. I'll get a phone call at least once every week or two from an agent saying, how do I rate this? It's unfortunately not just as simple as, oh, he has asthma, okay, he's standard, or okay, he's preferred. It's going to vary a lot given just depending on the details. Alrighty, so some of the things that we look at the closest when we're assessing asthma is going to be the age of onset, whether they were diagnosed as a child versus an adult. Childhood onset oftentimes has a very different profile. Sometimes it can be combined with allergies. There's a lot of things that can change as a kiddo is growing up. We do see children that sometimes outgrow this and sometimes it gets worse. So that is something we do look at very closely. One of the next things we look at is going to be the severity classification. Is this considered intermittent? It only happens every now and then. Is it mild and persistent? Is it moderate and persistent? Or is it severe and persistent? We're going to look at the frequency of the symptoms and the attacks, which are very different. Someone who's not familiar with asthma may just think that the attack is the symptom, but that is not necessarily the case. There is also a difference in whether or not these are daytime symptoms or if they're causing nighttime awakenings. That's something else that they're gonna want to look at. They're going to take a close look at medication usage. Is this client using inhalers only? Is it inhaled steroids or is it just a rescue inhaler? Is it oral steroids, something they're taking daily? Is it just an occasional inhaler, kind of, like exercise-induced asthma? You may only see occasional use. Or is this person dependent on their inhaler or their oral steroids? We're going to look at the history of attacks, especially those that require any kind of oral steroids or hospitalization. We're going to take a very close look at the lung function results, particularly the FEV1 and the FVC ratio. These are done during what we call a PFT or a pulmonary function test. Anybody who's been diagnosed with asthma should have PFT testing done in their records at some point. A lot of times we see that those are very outdated and the client's just been getting the same medication for the past 10 years. So it's not shocking when an underwriter comes back and wants updated PFTs so that they can see those FEV1 and FVC levels. They are going to look very closely at any hospitalizations or ER visits that have occurred in recent years. We have a lot of asthmatics who've never been to the hospital once. They've never had a bad attack. Their oral medication or their daily inhaler may keep that at bay. You know, and then we have others that have had severe attacks and had multiple ER visits or hospitalizations, and those are going to be underwritten very differently, obviously. Another huge consideration is going to be their smoking status and history. Smoking combined with asthma is obviously going to be very concerning. That's something we're not going to want to see. The longer they have been a non-smoker, the better. And then we are definitely going to look at comorbidities such as COPD, sleep apnea, obesity, all these things that can complicate that asthmatic history and potentially increase its severity and therefore its risk. Each of these details is going to be critical in assigning the appropriate rating and determining whether someone is considered low, moderate, or high risk as we underwrite them. All right, so how do we classify the severity when it comes to asthma? Most underwriting manuals will classify asthma into 4 categories. This is determined by a mix of the symptoms, the functional testing, and the treatment history. So basically what we'll see is with intermittent asthma, the symptoms are occurring less than 2 days a week, and the nighttime awakenings are happening less than 2 times a month. On their PFTs, we're going to find that their FEV1 is over 80%, which is favorable, and that there is no interference with their daily activities. You know, they can go to school, they can go to work, they can function, they can participate in gym class or go outside and enjoy the fresh air. Those are often going to be standard or better. We have seen all the way up to preferred on those if things are well managed and the symptoms are mild. For mild persistent asthma, we're going to see symptoms that still happen. They're going to happen more than 2 days a week, but not daily. And the nighttime awakenings are going to be in the 3 to 4 times a month range. That FEV1 is still going to be over 80%. And at that point, because they're a little bit more symptomatic, we're going to see somewhere in the standard range, maybe a table 2. You know, if they're not needing a rescue inhaler or anything like that, then standard is typically still going to be possible. But if that rescue inhaler is necessary, then that's when we start seeing those table rates start to pop up. All right, when we get to a moderate persistent level, this is where we're seeing daily symptoms. We're seeing nighttime awakenings that are more than once per week. We are seeing daily use of inhaled steroids. Usually on the FEV1, we're seeing a decrease in that number down in the 60 to 80% range. And then the FVC is usually reduced. This is where we start seeing the table 2 to 4 range. That daily inhaled steroids is definitely a key factor. So that's something to keep in mind when you are talking to your clients. I do not expect anybody would ever remember what an FEV1 or FVC is where that's gonna fall on here. And when we get to the more severe persistent symptoms, that's when we're gonna see symptoms throughout the day. Frequent nighttime awakenings, chronic oral steroid use. They need that medication in order to function. The FEV1 is typically going to fall under 60%. And this is where we're going to see the higher substandards or even a decline on this. And just to kind of visit again what the FEV1 and the FVC actually mean. So the FEV1 is going to be the forced expiratory volume. This is how much air you exhale in 1 second. And typically they'll do this a few times. There'll be an FEV1, an FEV2, an FEV3, and each of those will have a percentage that's applied to it. The lower that number, the more that suggests there's an obstruction. And so this is why we want to see it up over 80%. The FVC is your forced vital capacity. That is going to be the total during the entire test combined. So again, this is usually done during what we call a pulmonary function test or a PFT. So anytime you're speaking with an agent or a client, if you can, find out how did your last PFT go, they probably won't know the exact numbers, but they should have an idea, or if it was great or it was good. They may not have any clue at all, and that's okay. Like I said, a lot of people don't get them done as often as maybe we'd like to see. Doctors and clients seem to get a little complacent at times when, the client says, oh, things are going well, I haven't needed my inhaler for a while. They just kind of keep treatment going as it is, and they don't do those tests as much as underwriters may like to see. And so again, you'll oftentimes see an underwriter come back and ask for a more recent test, because that does seem to fall through the cracks. All right, so what are some of the red flags that underwriters are going to look for? There's definitely a few. They're going to have us sit up and pay closer attention. One of them is going to be frequent attacks, requiring those oral steroids 2 or more times per year. That's definitely going to be an issue. And as a side note here, I will say that we do see an increase in those during high allergy seasons. A lot of times asthma can be driven by allergies. And so if it is allergy driven, it's important that little details like that are noted either on the paramed exam or a cover letter, because if we can correlate that with allergies and kind of show that it's not the norm, that can kind of work in your favor. Some of the other things that are going to be a red flag, chronic steroid dependence. If they are requiring an oral steroid or a daily steroid inhaler in order to function, this is going to be a red flag. We're definitely going to want to see up-to-date PFTs there, and doctor's records, hospital records, to make sure there's not been any major attacks or hospitalizations. Hospitalizations or ER visits in the past year, obviously we don't like to see those. That means things are not well controlled. An impaired lung function, if that FEV is under 80% or that FVC is reduced, that's going to be a red flag. Nighttime symptoms disrupting your sleep, that's definitely a red flag. Those are less common than daytime symptoms. So when they start to happen at night, that definitely brings some attention to it. Heavy rescue inhaler usage. We may see one asthmatic who hasn't used their rescue inhaler at all in the past year, 5 years, 10 years. They've never needed it. They just have it. Others, if we see they're needing to use that often, it's being refilled every month. That's definitely going to be a red flag as well, that things are not well controlled. Again, comorbidities such as COPD, obesity, obstructive sleep apnea, or smoking. This is definitely going to prompt a little further digging to make sure that that things aren't more severe than we're seeing, and those can all be bad working together. So we need to know that all of those are well controlled and all being treated appropriately. Occupational exposure, this can be to dust, to chemicals, to allergens. This is something we look for. If we've got somebody who's a heavy asthmatic and they work with chemicals and they're a smoker, these are the kind of things that are going to count against them. So we definitely look at occupational exposure and lifestyle situations. And then finally, non-compliance with treatment. If someone is not following their prescribed plan, the risk definitely goes up for them. So if a client has been prescribed an oral steroid, we'd much rather see them compliant and see that that is working than find that they're not using it. And because they're not using it, they're now using the rescue inhaler all the time. So compliance with what the doctor has recommended and the treatment prescribed is going to definitely be key. Let's see here. So these indicators, when you see these factors in a client's history, definitely prepare them for the possibility of a higher rating or even a decline. If you know they're a smoker, they're not taking their medicine, they said they don't like the way it makes them feel. personally got a child with allergies and asthma and the whole 9 yards, and he's had it forever, and he has to take an oral steroid. He has to take an oral inhaler steroid as well. One's a pill, one's an inhaler, plus he has his rescue inhaler. Um, that's the kind of thing that I know if he's not using those, we're going to have some issues and have him back in the hospital. But as long as he's on them, he's perfectly fine. And so as long as they're compliant, that just makes a big difference. Just make sure that that's the case when you're talking to them and getting ready to quote or pre-screen this. Find out where they're at on that. All right, so let's look at a couple cases, just see how different they can all be. This very first case is going to be a 28-year-old man, had mild intermittent asthma. He does use his inhaler once a month. He's had no ER visits. He did have recent PFTs done, and that FEV1 was at 90%, which is very good. Lifelong non-smoker, so that was a non-issue. No other comorbidities that were needed to be worried about. This gentleman, we were actually able to place at a preferred non-smoker. There were some companies that came in at standard, but preferred was possible with multiple carriers. And case number 2. We ran into a 45-year-old with moderate persistent asthma. This gentleman was using daily inhaled steroids, so it was an inhaler, it wasn't an oral pill. He'd had 2 ER visits in the last 12 months, and his PFTs were in that 70% range, so they were slightly decreased. That was showing there was definitely some obstruction there. He was a lifelong non-smoker, so that did work in his benefit, and we were able to find him multiple offers in the table 2 to 3 range. I do believe there was also one standard in there. We were not able to find a preferred, but the majority of the carriers came back in that table 2 to 3 area. And then our third case was a 60-year-old. She had severe persistent asthma. She was on chronic oral steroids. She took a pill every day. She was hospitalized twice last year, and her FEV1 actually was down in the 55% range, which is decreased significantly more than we'd like to see. She was also a smoker, and this unfortunately did result in all declines. The fact that those PFTs were so low and she was still smoking, now we've got a lot of extra risk here for things like COPD. And so, yeah, this one was a big no-no, unfortunately. But, coverage may be possible in the future if she stops smoking, continues on her recommended treatments, and those hospitalizations and attacks decline. So as seen, you'll see the lung function values and that steroid use strongly affect the outcomes. And so this is just a clear example of why those little details matter when you're getting ready to quote or pre-screen one of these clients. All right, so when it comes to treatment and management factors, most underwriting guidelines emphasize management strategies when they're evaluating this asthma. And some of the favorable things that we're going to look for is someone who avoids allergens and irritants, both at home and at work. I know it's kind of hard to avoid those, especially if you like to be outdoors or your asthma is allergy induced. But, if you're not working in a chemical plant, you're working in an office every day, those kind of things are going to be looked at differently. If you're not working in the coal mines, if you're not working in dusty environments, these things can be taken into consideration, believe it or not. We do try to look at the whole picture and just take a holistic approach when we're underwriting these. Some of the other things that will help is being up to date on your vaccinations, whether that's the flu, pneumonia, depending on your age, COVID-19, depending on your risk levels. I know not everybody qualifies for each of these vaccinations, but the people that do qualify and whose doctors have recommended them due to their medical conditions definitely should consider those, and that can sometimes help in our decision-making process. Another huge favorable factor is going to be compliance with any prescribed therapy. It's always key to be doing what the doctor's recommending. If you're not taking the medications that's been recommended and you're having attacks, this is not going to bode well. We want to see compliance with any prescribed therapy and see that it's helping. If you are using peak flow meters at home or home monitoring, that can be of some assistance. I can't say we see that very often, honestly, but if they're available, it can definitely be taken into consideration. And then allergen desensitization. If you are diagnosed with asthma and have bad allergies and you're doing some of that immunotherapy like the allergy shots every week or every 2 weeks, sometimes it's monthly. I've seen that done a lot of different ways. That can actually be taken into account as well and could be favorable when it comes to the underwriting. Us being able to see that you're proactive and that you're compliant and that you're taking every step to ward off any asthma attacks, that is going to be to your benefit. So when a client does demonstrate that strong control, that preventative care, it just helps mitigate all underwriting concerns at least a little bit, and some credits can be given. So what does this mean for you as an agent? Some tips for the agents and the advisors, for those working closely with these clients. Here are some of the most practical things you can do. Gather a detailed medical history up front. The more information you can get to me, the better I can quote, the more accurate any pre-screens are going to be with any particular carriers. The more information they have, the better. Ask specifically about any medications they are prescribed and how often they are used. And I say medications that are prescribed, not just medications that are being taken, because the thing is if an underwriter sees medications being prescribed, but the client's not taking them, we need to know those things, because that could make a big difference in a lot of different ways. They may be prescribed, let's say, an oral inhaler, but they're not using it because they haven't needed it in the last year. They've been fine without it. We need to know that, because if they don't need it, we don't want to assume they're on it. And if they're not compliant, we also want to know that. So we'll want to know both what's prescribed and what's being used. Let's see, let's find out when their last ER visit or hospitalization is, or if there has ever been any. Sometimes there's none. That's great news. But if there are, we need to know about those so we can include that in our pre-screens. We need to be very clear about any smoking and lifestyle factors. Again, are they working in dust and dirt and chemicals and coal mines and the factories? Just that can make a big difference, and we'll want to know that when we're shopping this out. Ask about those FEV1 results and the lung function test if the client has them available. If they don't, that's okay. One thing, modern technology has made it really easy for clients to hop on to a patient portal and pull those things, whereas, 5-10 years ago, that wasn't necessarily the case, or people weren't as familiar with them. Even though they were available, people didn't really use them often, but we're seeing it all the time now. I get screenshots from agents all the time from clients who said, hey, I just went and pulled this from my portal. Looks like I did it 5 years ago. I don't even remember doing it, but here's what it shows. So if that's something they can do, that is wonderful. We will definitely want to clarify the number of steroid courses or hospitalizations in the past 1 to 2 years. Maybe there wasn't a hospitalization. Maybe they just went to their walk-in clinic because they were having a really rough season due to the fall allergies. I speak from experience. Those are no fun. And people will go into just one of the walk-in clinics and get a number of different prescriptions. Sometimes that is steroids. It's not always a hospitalization visit or their PCP that can give those. So definitely find out if that has been an issue for them at any point in the last year or two. Ask about those night symptoms and any inhaler usage. And if they do say that they have had to use their rescue inhaler, ask a few more questions. Find out, was this exercise induced? Was this allergy induced? Were you just sitting at home on your couch watching TV when it came on? Get some details to that attack or symptoms, if you will, because that can also play a big role. If I can tell an underwriter, yes, he was hospitalized 6 months ago. However, he was sitting around a campfire in the middle of fall, and the weed pollen count was really high, and the smoke was blowing right at him from the bonfire. That's going to make a huge difference as compared to, I was sitting at home on the couch and watching the news, and all of a sudden I couldn't breathe. Those are going to be viewed very differently. Verify that vaccination status. It's not a make or break deal by any means, but like I said, it can be taken into consideration, especially if we're dealing with an older client where that pneumonia vaccination is available. That can definitely work to their favor if they are up to date on those recommendations. And then it's always key, just set realistic expectations early on about possible ratings. You and I and everybody who's worked in this business for any amount of time knows that the worst thing you can do is go back to a client with an offer worse than we originally quoted. Then you have to resell the case. So it's imperative that we set those expectations early on and let them know, just because your neighbor next door got preferred, their asthma is not the same as your asthma. Every client is going to be underwritten differently depending on their specifics. And obviously, the smoother the underwriting process is going to be. A well-prepared application with good field underwriting notes, it can save weeks of back and forth with the carrier. So really, just the more information that you can give us up front, the better. So what are some of our key takeaways from this? Is that asthma is common. It is very, very common. We see it all the time. It can sometimes be mistaken for allergies. They can sometimes coincide together, but it is highly variable in underwriting. We will see everything from a preferred to a decline, just depending on all those specifics. Obviously, severity and control. These are going to be measured by the symptoms and the lung functions, and that is going to drive the decision. That's going to be the ultimate deciding factor on how this all plays out. Attacks and steroid use are going to be major differentiators. If they're having multiple attacks, constantly needing steroid use, this is going to be viewed very differently than someone who's never had an actual full-blown attack, never needed steroid use, just carries their inhaler because sometimes they want to run a 5K and that makes it hard to breathe. And preventative care. We want to see those vaccinations, those age-appropriate, health-appropriate vaccinations. We want to see compliance with any recommended treatment, and obviously lifestyle factors matter. Smoker versus non-smoker, athlete versus non-athlete, all those different things. And at the end of the day, strong field underwriting is going to help secure the best offer for your client. The more you can tell us up front, the more accurate we're going to be in our assessment, the less back and forth you're going to have between yourself and the home office, and so on and so forth. So how can IAMS help? Well, we have lots of case studies. I can look at previous cases, I can look at current cases, I can reach out to the carriers and ask for guidance if there's something unique about the situation. So don't ever hesitate to reach out. That's why we're here. Additionally, we do have these wonderful fact finders out on our website, iamsinc.com. We have some that are very generic. It's a full client profile, health screening questionnaire, ask all the different avocation, financial, medical questions, very high level, but still gives us an idea of what we're working with, and can be a great opportunity before you even meet with the client to send them this and get an idea of what you're walking into and what kind of questions you're going to need to ask. Another great thing on this is, somebody answers a couple of these questions. Yes, we find out that they have, let's say asthma and COPD. then you can reach out right away and say, hey, they sent me this questionnaire. I'm meeting with them next week. What else do I need to know? When that happens, we then have these very handy dandy questionnaires that are ailment specific. There's an entire NAILBA guide on our website that you can access, or you can call me, you can call your sales director. We can send you those, but they're very specific. There's one questionnaire specifically for asthma, one specifically for COPD, and a million other things, arthritis, AFib, aneurysms, cancer, you name it. There's a questionnaire for that. So please do feel free to visit our website and grab those, or call us and we can send them directly to you. You can additionally reach out directly to me. I'm at andrea@iamsinc.com. You can call me at 800-255-5055, and we can talk through the case. You can work with your sales director. They are just as well versed on a lot of these things, and what they don't have right at their fingertips, they can reach out to me, or they can also send you those questionnaires. And then once those are received, we can pre-screen those. We can send out quick quotes to all of our carriers and find who's going to be the most favorable for your client, because again, not all carriers, not all ailments are created equal. They're all going to be very different. And so shopping these in advance can make sure that we get this with the right carrier the first time, and we're not having to pivot on the back end or resell the case because expectations were not set in the beginning. And with that, of course, please follow and like us. We are on Facebook, we are on LinkedIn, and we sure do appreciate you. And thank you for joining us today. If you have any questions, please feel free to reach out. Thanks so much. Take care.